Hey everybody, welcome back. We'll be starting with the roots and pharmacokinetics. So, chemotherapeutic agents is just their definition. They kill pathogens and malignant cells, while pharmacodynamic agents will act on normal cells. So these would be insulin medication, high blood pressure medication, and the like. The drugs are the three names: the chemical, the generic, and the brand or propriety names. There's a bunch of factors that affect administration, the physical and chemical properties. So whether the drug is a liquid or a solid or a gas, and that's going to affect like how to administer the medicine. The pH of blood, urine, etc. is going to also affect the administration route. The site of action, so whether it's going to be like an intramuscular injection, so where do you inject that, usually in the deltoid or like the buttocks. The effects of like the stomach acid, so that would also kind of go under the umbrella of the pH. And the first pass metabolism, so how the liver metabolizes things. The rapidity of the response, depending on how much is in circulation. The accuracy of the dosage, that depends on the kind of the metabolism, but also the body weight of the patient. And the condition of the patient. Are they young, old? Are they sick? Are they healthy? So the two main routes are the local or systemic routes. The topical routes is transdermal through the skin, buccal in the mouth, rectal, sublingual under the tongue. There's only a minor difference between buccal and sublingual. Buccal is like you put the medication in the cheek. Otic in the ear, ocular, and epidural. So this is going to be injected in the spinal cord. There's inhalation, which is going to be the dry powders and liquid sprays. Oral, all of these. Parenteral, and subcutaneous, intramuscular, and intravenous. So this would be the parenteral routes. As you can see here, depending on what injection you need, it determines the angle of the needle. So first pass metabolism is going to be when the drug is absorbed first through the intestines and then is transported via the portal system to the liver. The liver is going to break down some of the drugs or conjugate it, and then it's going to be released into systemic circulation. Bioavailability is the amount available for the body to use after the first pass metabolism, and it is also the amount that is in systemic circulation. Well, just to be very clear, it's the amount of drug that can be used. So it's the amount that is not bound to a carrier protein. So here is the basic pharmacokinetic considerations. This is going to be the duration of action, and there's going to be the therapeutic range right here, and the rate of absorption is very critical because depending on how it's absorbed and how it's eliminated, it's going to determine toxicity. So the local route is going to be administered directly from the site of action from an accessible approach. What does that mean? Can you, the patient, do it to yourself? So can you swallow? So we can consider an oral route. But if somebody who is paralyzed and they have a problem with glutination, then we have to consider other routes. So aerosol, breathe it in. Urethra, it can be a jelly or a bougie. Vagina, there's going to be the pessaries and the vaginal tablets. If you want to go deeper, there's the intra-articular, intrathecal, infiltration, and arterial injections. Arterial is very rare. They're mostly in for chemotherapy, and these usually have a permanent port in the like subclavian or the internal jugular vein. But these are pretty rare because these ports are like semi-permanent. It's hard not hard, but there's a procedure that you have to go through. So there's also a very high risk of infection. So in systemic circulation, the drug will reach the site of action. And the oral advantage of a drug is that it's common, it's the safest and convenient, and it's nice and cheap, and somewhat painless. The disadvantage is it's the slowest to be absorbed, and it has a low bioavailability, of course, because of the first pass metabolism, and some medication can irritate the stomach. Sublingual or buccal advantage, it's faster because it's absorbed into the bloodstream and the liver is bypassed, so there's no first pass metabolism. The disadvantage is that it has to be water soluble. The rectal advantage is that if you insert it in deep enough or like shallow enough, the first pass effect is bypassed. If you go in too deep above the levator ani, above the pectineal line, it will be subject to first pass metabolism. So the problem is, of course, there's going to be irritation, hemorrhoid formation over like time, and like I said, you have to be pretty precise. You have to insert it below the pectinate line. The cutaneous advantage is that you can give a long duration kind of drug and sustained administration. So the disadvantage is that, once again, it can only be lipid soluble because you have to pass through the adipose tissue. The inhalation advantage is that it's the fastest absorption due to the large amount of surface area of the alveoli, and it bypasses the first pass metabolism, and there's a local effect, so it's going to occur like immediately. However, it's short. The technique is pretty sensitive, and over time you can use like nosebleeds. The parenteral advantage is fast. There's no gastric irritation, and the liver is bypassed. However, it's expensive, it's invasive, it's painful, and there's of course the local tissue injury. The subcutaneous only is available for the small doses, and in the intramuscular advantage is that you can inject a long-acting preparation. However, there is a risk of hematoma. The IV advantage is as fastest. The irritating medication can be injected in a large volume, and dose titration is possible. So the disadvantage is that since the bioavailability is 100%, it's risky. The chances of an overdose or toxicity is high. Intradermal is injected in the skin. Of course, there's blister or bleb formation risk. Occusert is a new kind of drug route, and it's basically a very high-tech contact. So you insert the contact, and there's a reservoir of medication, and it will release the medication slowly. This is usually to treat glaucoma. Liposomal preparation is when a drug is covered by lysosome, and of course it is expensive. It's very new, that's why, and it's a very good drug because this is a drug that's able to be absorbed through any lipid membrane. Pegylated preparation, same kind of idea. Instead of just liposome, the drug is covered by polyethylene glycol. Like I said, it can be absorbed through lipid membranes. However, it is also expensive. These two are very new. I really doubt you will be tested on it, on like the USMLE, but it's useful to know. And of course, there's the insulin pump therapy. This is going to be a form of the subcutaneous injection. Okay, so pharmacodynamics. Absorption is dependent on the drug form. So is it a lipid? Is it aerosol? Is it a solid? And distribution is going to be affected whether the drug is stored like in the fat or is free in the system. Metabolism is going to be subject to like the first pass, or and that's the biotransformation, and then excretion through the urine, the feces, sweat, and saliva. Absorption is basically the movement of drug from the administration or site of administration into circulation, and it's affected by lipid solubility, of course, how the body is able to just take it in the cells, concentration, surface area, vascularity around the root, and the rate of absorption. Inhalation is fastest, oral is the slowest. Exercise will increase the absorption from the intramuscular route because you are increasing the blood flow. Epinephrine will decrease the absorption from both the intramuscular and subcutaneous route, and shock will decrease the absorption from the intramuscular route and subcutaneous route. So it's a little surprising because you'd think that with vasodilation, body would be able to absorb things more, but that's not true. Because even though there's vasodilation, the blood pressure is very low. So actually, there's a very sluggish blood flow. So the permeation of the drug is the translocation of the drug across the biological barrier membrane, and the passive diffusion is going to be subject to the Fick's law, and there's going to be, of course, facilitated diffusion and active transport. We should all know this. So basic drugs are going to be ionized in an acidic environment, of course, because the acid is going to give the base hydrogen, and acidic drugs are going to be ionized in a basic environment because the acidic drugs are going to be giving away the hydrogen. When the pH is equal to the pKa, it's going to be 50% of the drug is ionized, and the pH minus the pKa is going to determine the ratio of ionization. So when pH minus pKa, it's going to be 50% automatically, and if there is 1, so if the pH, let's say, is like 7, pKa is 6, equal to 1, 90% of the drug is ionized. If it's 2, about 99% of the drug is ionized. Ionized, lipid-soluble, water-soluble, polar, hydrophilic, non-absorbable, that basically means the same. That just means the body can use. And a protonated base, just to repeat myself, is ionized. So when the base is given a hydrogen, so base in an acidic environment, and a protonated acid is going to be non-ionized because it has given away its hydrogen. So that's it for now. Thank you for your attention and good luck studying.